Bangkok, Thailand. She's one of the most beautiful professors in Thailand. She's a professor of ophthalmology at Surat Medical School, the biggest one in Thailand. And she also the Retinoblastoma Authority of Thailand. All the cases go to her. May I invite her to speak? She was speaking on retinoblastoma, introduction, classification, features. Thank you.
Thank you very much. Now I'm embarrassed. I have to say that I need a little more light here, please. Okay. Ladies and gentlemen, it is an honor to be here with you today. I'd like to start my presentation with a quote, "Cancer is a word, not a sentence," by John Diamond. He's a journalist. The word is just a word. We get to choose how the sentence is written. We can choose how the word is applied in our life. And I believe we are in this room because we choose to understand more about retinoblastoma, the most common primary tumor in children. The incidence of retinoblastoma is approximately 1 in 15,000 live births. However, this is not distributed equally around the world, with more cases in developing countries. Worldwide, there are 8,000 to 9,000 new cases of retinoblastoma annually. In Thailand, the report from the Thai Pediatric Oncology Group stated approximately 40 new cases per year. For us, it is without question that any child with leukocoria needs to be examined by an ophthalmologist right away. But it is still a great challenge to spread information to the public how serious this white reflex is, especially in developing countries. Most of the time it would take more than 6 months before the parents bring their child to the doctor. Although it is not as often as in the past to have children with proptosis due to orbital invasion from retinoblastoma, these children reflect an insufficient education to people. It appears that we are trying to keep up with the new treatment methods for those severe cases, but in fact, an early detection would be the best treatment. There are many other conditions that can cause leukocoria in children, such as cataract, Coats disease, retinopathy of prematurity, intraocular parasitic infestations. And this is one example. This child developed leukocoria in the right eye, and this eye appears to be smaller than the left, which is a clue to the diagnosis of persistent fetal vasculature. With pupil dilation, we can appreciate the retrolental membrane attached to the posterior lens surface. The membrane can be small and located centrally, as in this case, or it can expand and obscure the fundus view. In practice, we divide retinoblastoma into 2 main groups, intraocular and extraocular retinoblastoma. Extraocular group can be divided further into orbital and metastatic. After examination under anesthesia, the disease staging will be determined. Currently, there are 2 commonly used classification systems for intraocular retinoblastoma, which I will be presenting. In the past, enucleation and external beam radiotherapy were the primary treatment for retinoblastoma. In the 1960s, the Riss-Ellsworth staging system were developed to predict the chance of preserving the eye after radiotherapy. And here is the detail of the Riss-Ellsworth staging system. This system is based on number, size, and location of tumors and the presence of vitreous seeding. According to this system, the eye will be with a small tumor posterior to the equator would have a higher chance of eye preservation, and the eye with any lesion extending to the ora serrata would have unfavorable prognosis. This picture demonstrates 2 small endophytic tumors anterior to the equator. Using Riss-Ellsworth staging system, this eye will be group 3 with doubtful prognosis for eye salvage. And during the past 20 years, primary treatment with external beam radiotherapy has been replaced by systemic chemotherapy combined with local treatment due to the increased risk of second malignancy after radiation. Driven by this transition, the new classification system, which staging from A to E, was developed by the International Collaborative Group under the leadership of Professor Aileen Murphy, pediatric ophthalmologist at Children's Hospital Los Angeles. The new classification is based on size and location of tumor, as well as the presence of subretinal or vitreous seeding. This system predicts the potential for eye salvage with modern therapy and also determines the appropriate treatment for each group. This picture shows the group A eye. It defines small intraretinal tumors away from the fovea and the disc. Again, this is a group 3 eye by Rees-Ellsworth staging system. It will be group A by the international classification and easily managed with local therapies alone. This slide shows group B eye with tumors larger than 3 millimeters. This group also includes those tumors in the macula or close to the optic disc or with subretinal fluid. This is a group C eye showing tumor with focal subretinal seeding within 3 millimeters of tumor. Those with vitreous seeding within 3 millimeters of tumor are also included. Primary systemic chemotherapy would be recommended for group B and C eyes. A tumor with diffuse subretinal or vitreous seeding will be classified as group D. This eye may require systemic chemotherapy combined with other treatment modalities such as subtenon carboplatin or external beam radiotherapy. These are examples of group E with extensive tumor occupying more than 50% of the globe or tumor seeds in the anterior chamber. Treatment recommendation for this group would be enucleation. Another staging system that has been used but not very often in retinoblastoma is the TNM staging system. This system describes both intraocular and extraocular diseases using alphanumeric codes. T describes the size of the primary tumor and whether it has invaded nearby tissue. N describes regional lymph nodes that are involved, and M describes distant metastasis. It has been shown that the higher tumor clinical TNM stage and the more advanced international classification group at presentation are associated with higher frequency of high-risk pathologic features and may predict which patients should receive adjuvant chemotherapy. I hope this presentation is informative, and thank you very much for your attention.
Questions for our speaker? So I have a little question maybe or a comment. So you described 3 very important staging systems, Rees-Ellsworth, International Classification of Retinoblastoma, and TNM. Which do you prefer, and which do you feel is the most practical?
Okay. Of course, I think the international classification system is very useful, and it's we can communicate with other doctors with these systems, and it's related to, it suggests the way we treat patients, the modalities that we can use in each group as well. So I use the international classification for intraocular retinoblastoma.
So I would agree too. In the States, we tend to use the international classification. I think it's a good classification because A, it's very simple to remember. B, it's very predictive. So anyone who's thinking about designing a classification, you always want to make your classification as simple as possible so that people can remember it, especially when you're under pressure in a clinic to classify the patient really fast so you can move on to the next patient. So there have been some new classifications that have come out, the AJCC classification 8th edition. It's somewhat difficult to remember.
Yeah. I have to put out a paper in the
Same here too.
Thank you very much.